Hi there. At this point in the course, we are going to look at COVID-19 through the lens of sociology of health, with a focus on social inequality. By the end of this mini lecture, you should be able to define the social determinants of health approach. Some key questions to pay attention to during this module are: how can sociology explain differences in health outcomes? What inequities existed for marginalized and racialized populations prior to the COVID-19 outbreak? Which of these inequities have been exacerbated under COVID? And how has COVID-19 impacted inequities in health outcomes specifically based on socioeconomic status, gender, and race? So let's start by thinking about what health is. What does it mean to be healthy? How would you describe someone who is healthy? It's important to recognize that being healthy doesn't just mean you're illness-free. To be healthy is to be in a state of complete mental, social, and physical well-being. So why does health matter to sociologists? Given that health is more than our biology, it's important to study health from a sociological perspective. Sociologists recognize the roles individual health, population health, healthcare institutions, and health inequities play in the function of society. Fundamentally, sociologists aim to look beyond the symptom level of illness and disease and treat the root causes of health inequities and experiences of health and illness. Focusing on these root causes is known as a social determinants of health perspective. Let's look more at the sociological approach to the social determinants of health. Sociologists often use the metaphor of a stream to illustrate the role of sociology in health promotion. In this picture, we see a stream. Upstream in the top right, there's a broken bridge. Several people fell off this bridge and are drowning down the river in the bottom left. Social determinants of health are equivalent to the bridge in this scenario. While the medical field focuses on the critical job of saving the lives of the people drowning in the river, sociologists are responsible for turning the attention upstream to find and fix that broken bridge. This bridge could be, but is not limited to, race and ethnicity, gender and sex, sexuality, environment and place, politics, and socioeconomic status. These factors impact experiences of health at the individual and population levels. In sociology, we work to prevent the bridges from breaking in the first place and to fix them when they do. For some, there have been many bridges broken, and for some, their flotation devices and life jackets were popped, placing them in more danger than others. This is the concept of intersectionality, a concept used to acknowledge that many individuals live at the intersection of several factors that impact their experiences of health and healthcare. For example, in Canada, an Indigenous woman living in Prince Rupert will have a drastically different experience of health than a white woman living in the Lower Mainland. This is an example of access to healthcare being impacted by several broken bridges, such as gender, location, ethnicity, and colonialism. Another example would be individuals living on Vancouver's downtown east side, for whom most bridges have been broken, building significant barriers to access healthcare. Meanwhile, COVID-19 regulations have acted as further barriers, popping the inflatable devices of harm reduction, such as using substances in groups to prevent fatal overdoses. We will examine the impact of many of the social determinants of health on health outcomes in the context of COVID-19 throughout this course. Socioeconomic status is one of the social determinants of health we will be discussing in depth today. Socioeconomic status is the social status or social class that individuals acquire based on their occupation, education, and their income. A doctor with a medical degree from Johns Hopkins University who works in the private sector will have a significantly higher SES than the caretaker who dropped out of high school and is now working in the doctor's office, making a minimum wage. While these are extreme examples to highlight the differences, our society is built on a gradient of SES, where individuals with higher SES are afforded better life chances and broader opportunities and flexibility than their low SES counterparts. So why does socioeconomic status matter for health? Just some examples include individuals with high SES can afford health insurance and pharmaceutical coverage. They will often have a job with time flexibility built in to see the doctor, dentist, counselor, physio, etc. They can afford to participate in clinical trials and pay for private medicine. They have the opportunity to make healthy food choices, for example, eating organic, local, and fresh food regularly. High SES housing is often located near a park or beach, whereas low SES housing tends to be closer to a highway or factory. This shapes daily life and long-term health outcomes. For example, we know that living close to a highway is associated with higher incidences of asthma in BC. SES also had a significant impact on individuals' experiences of COVID-19. In the context of COVID, SES will determine who can access tests. For example, the Kardashians getting tested because they can pay for it, not because they had symptoms. High-paying jobs will allow sick leave or opportunities to work from home when ill. Living conditions create pre-existing conditions that put individuals at higher risk of the effects of COVID-19. And there has been a significant discrepancy in who has been able to stock up on food and supplies in preparation for nationwide lockdowns and social distancing.